All right. We go to the next questions. So Amjad, you want to take next question?
Yes,
Number 4.
we'll come back, Doctor.
Thank you, Amjad.
Okay. 71 years old woman, currently smoker, with a history of ovarian cancer, who was just hospitalized 1 month ago for acute myocardial infarction, presented with a 12-hour history of bilateral leg pain and paresthesia. An examination, she has a diminished motor and sensory function, and her legs are purple and cold. She has a remote history of bilateral iliac stent. The CT angiogram image are showing in figure 1 and 2. The best management plan is, so
Okay.
this is a patient with a malignancy history and history of iliac stenting bilaterally, presented with a symptom of acute threatening limb, acute limb ischemia, 12-hour.
Okay. So it's a 2B also, because yes, in
2B.
Paris, the foot are cold, and 12 hours already. The only thing they mentioned to you, they said everything, they put it there for a reason. Said an acute MI, where is it? A month ago.
Recently,
okay?
yeah, 1 month ago.
I just try to tell you, don't think about aortic bypass. This is for sure.
Yeah.
This is, you can tell from this, they want to tell you she's not ready for major surgery. Put it this way, not for major surgery, okay? But at the same time, she's a 2B. She already have a decreased sensations, legs cold. So you have to do something, okay? And she has bilateral iliac stent. So that means it's not an emboli. This is acute and chronic. So you already have a chronic vascular occlusive disease. And remember what we said in a chronic, acute and chronic, you cannot solve them with a simple embolectomy. Most of the time you end with a bypass,
Yes, yeah.
So it's different when you come with a normal artery and get an emboli in the aorta. So here you can look at an angiogram, you see a complete occlusion of the aorta here, complete occlusion of both stent, So this is acute and chronic. We don't know how her artery before, but mostly she has a disease aorta, disease, iliac artery. Even though it looks nice for you to do bilateral embolectomy, but I don't think this will work because of acute and chronic, Even crossing the stent, if you got endovascular, I don't think this is, you can able to cross the stents, with this all occlusion,
Yeah.
So this will not, endovascular, the same to thrombolysis, you have to cross the lesion. And second thing, you don't have a time. Sorry, you don't have a time for thrombolysis, 12 hours already, okay?
Yes, yes.
And the second trick, they show you, what this artery they show you? What they did here, the image. Second, why they show you
auxiliary artery
why
for
they show you?
extraatomical. For
So
other option, for bypass.
So they give you the option, they give you the answer right away. They see, they tell you, go and do axillo by fem. It's very simple. I mean, this really, they give you the question and the answer,
Yes.
But if you didn't put this picture, it would be a bit more difficult. But when you put this picture, because why does it show me the axilla? Why? I don't need it, But it works, they push you to go to the axillo by fem. Okay, let's see what's the option here.
Okay, A, aortobiofemoral bypass and fasciotomy. We said no, so aggressive for her. Yes.
Okay.
Percutaneous endovascular thrombectomy with a stenting of the distal aortoiliac segment. It will not work, as we said, acute and chronic.
And second, 12 hours,
Yeah, and
sometimes they work. Now, don't take me, my word. Sometimes they work. If you have acute and chronic, you can cross them with thrombolysis. But again, you already 12 hours, you already 2B. You already have a paresthesia and you have, so it's not good timing for that. All right.
Okay. Axillo-bifemoral bypass and fasciotomy sound good.
Okay.
Bilateral leg amputation, no.
No. That looks still viable.
Yes, it's still viable. Open thrombectomy with a stenting of the distal aortoiliac segments, same as you said. So I will go with the C.
Yeah. From the practical kind point, I mean, you can, that's usually, I can visual what I do. Because when you do our axillo by fem, you have to expose both common femoral artery, right? I need to open them up, correct?
Yeah.
Okay, so you can try, you never know. I mean, that's just out from this question. This question should be C, I agree. But in real life, when you open the common femoral, you can try, you'll get to your Fogarty. Maybe you'll be lucky, go all the way, do embolectomy, get good flow. And they do an angiogram, you see some, so you can do ballooning and stent, like a hybrid repair, Yeah. But you have to be prepared for axillo by fem. So I give it like, I open both the groin, open camofemoral. I'll try doing embolectomy. You know, just give us a chance. You never know. If my Foley went fine, I got good flow from both sides, then do a combination angiogram. If something I can fix with a stent, I will do like a hybrid repair. If it's not, then I'm ready for axillo biofem. I didn't delay anything. You see my point?
Yeah.
Because so this is from practical standpoint, but to answer this question, the exam axillo biofem bypass should be done, and fasciectomy, of course, because 12 hours.
Mm-hmm.
All right.
Yes.
Because sometimes different between what real life and what the exam. You know, exam have to be on the safe side. What the most reasonable, you know. But in real life, because you know every patient is different. Not every patient is the same. So sometimes you change your technique depending what the patient condition at that time. But in the exam, they consider all the patients the same. They want you to choose the most safe and appropriate answer for the question, which will be in this situation. All right. All right, so should I go back to Muhammad or anybody want from outside guys want to pick up questions? No.
Okay, Dr. Samer.
Yes, who is that?
It's me, Dr. Maitham.
Okay, you want to go? Go ahead. Let me give you the next question. Haitham, here we are. Number 5. Let's go to that. Okay.
Okay, so this is a 60-year-old man with a history of atrial fibrillation, presents to the emergency room with a 4-hour history of pain in the left lower leg and foot. On examination, the foot is tender to touch and cool with mildly decreased sensation. Plantar flexion strength is diminished 4/5. The femoral pulse is palpable and a Doppler signal present in the posterior tibia. The right leg has a palpable pedal pulses. An angiogram in the figure is obtained. Following initial heparinization, the most expeditious intervention to restore perfusion is.
Okay, before we go that, let's go with question. 60 years old, at fibrillation, 4 hours, okay?
So acute.
So acute, but 4 hours, so at least we don't need fasciectomy. Usually fasciectomy is 6 hours. I mean, according to the book. So this one, just to tell you that you have a time, and the foot, this is what, 2A or 2B?
There is decreased sensation and the plantar flexion also diminished. So this is 2B.
It's a mild decrease, in the sensation. So I think I will put it 2A,
2A?
Yeah, I think because a mild decrease, let's go back to the classification, see what, here we are. Where is it? Here we are. Decreased sensation, C2A margin, decreased sensation to the toe with a normal motor. So just decreased sensation. Whereas 2B, you have sensation and motor. Okay? So it's only sensation, 2A. When you have sensation and motor, we talk about 2B. Okay?
So Dr. Samer, in this patient, plantar flexion strength is 4/5. So it's decreased.
Yeah.
I mean, the motor is affected.
Okay. What about it like 2A/B?
Okay.
No problem. Yeah. But anyway, it's just tell you that you have a time. Put it this way. Forget about the classification. I agree with that. I said like parastatic damage. Yeah, 4 to 5. You're right. So you could put 2B. But at least it's not too bad that you don't have a time. So you have the time, if you want to do thrombolysis, or open repair. Anything else? I think that's all. So should be straightforward. So what do you think? What do you do? So where's the clot first? Like on
the clot is in the tibio-peroneal tract and the bifurcation and mainly involving the.
All right. So what options do you have? What options? How you treated this one?
This patient can be treated with thrombectomy.
Okay. How is the incision? Where you do it? Where's the incision? Will it be below the knee or groin?
Given the other picture, I think the other picture is for the SFA.
No.
I will go.
No, it's no SFA. No. This is popliteal. And this
the other
tibia.
one, on the right.
This is a posterior tibia. This is the foot.
Okay.
This is the foot. This is the posterior tibia. This is the peroneal.
Okay. So I think I will go for below knee incision.
Yes. So what's the advantage below knee than femoral? Why don't go from femoral?
It's better control for the vessels.
Not really.
And
What's the advantage of go below the knee? You see, when you go from above, you see the catheter goes straight, right? So most of the time your catheter will go all the way to peroneum. Rarely it goes to anterior tibia, posterior tibia, you know? So when you go this one, you can get a clot from tibial triangle posterior tibia, but you cannot select it from posterior tibial or anterior tibia. You know, this is the problem. You can do selective embolectomy, unless if you do like hybrid, you do like, you know, you put a wire through it and then you put Fogarty over the wire, which is not available in every place. You know, so in general, when I see clot below the knee only and the rest of the artery is free, the best way to go below the knee, because you can do selective embolectomy. You can clean all these three arteries. From one incision from below, cleaned up very well. From above, it's very hard really to clean them very well from above, especially three arteries, okay?
Okay.
The reason why we don't waste your time. Just go right away to the below the knee, open thrombectomy would be the best way, you know? Or you can do thrombolysis, but thrombolysis, you have to go from above, you know, either antegrade or you go from over the bifurcation and you can do thrombolysis, you know?
Okay.
So let's see option what they gave you here. Let's start one by one.
So A, catheter-directed thrombolysis via right pedal axis. I think the right is mentioned is palpable pulses. So why to go from the right?
Okay.
Yes, as you mentioned, is you go from higher up.
Okay.
So B, catheter-directed thrombolysis.
You want to go from the right, we go from the camofemoral because you got camo. You don't have to go from pedal, be too far. I mean, this is really no way can be right answer. So next one.
Catheter-directed thrombolysis via antegrade left pedal axis. It's already occluded, so it will be. It's not
really?
a suitable answer. Yeah.
Right. If you want to go from the left, you go from the left camofemoral. We don't go really from below up with thrombolysis. Because because the catheter sometimes it can occlude the artery, you know. So you want the artery to flow, so you can get the TBA going down. You know, if the artery is occluded distal, then the TBA will go everywhere, but doesn't go to that artery. And then second, you may damage the artery. So this is not good. We never do thrombolysis distal and backward. You know, if you're going to do thrombolysis, always you go from above, from again femoral. So if it be an answer, will be antegrade left femoral axis, you know, not pedal axis. Okay.
Okay.
So this is wrong.
So C, surgical thromboembolectomy via left groin incision. As you mentioned before, if you will go for embolectomy and there is only the thrombus and the embolus in the below the knee, we will go just below the knee.
I mean, yeah, but be careful. Below the knee, it's involved the tibial. If it's just involving the popliteal arteries below the knee, then yes, you can go below the knee. You can go from the femoral do embolectomy to popliteal artery, no problem. If the three arteries are free, no clot. But when the moment you see clot went down to the tibial artery, then you have to do below the knee embolectomy. Okay.
What if the, as you said, what is the occlusion in the popliteal artery, and we can go from below knee and get it retrograde from up and pick it down, bring it down, making control for the three vessels, the three tibials. Can we do it?
See that question. If the clot only in the popliteal artery?
Yeah, and the three vessels is clean. I mean, there is no clots, and we can make a control for them. So there is no imply we will shower down to occlude one of them.
Usually, when you see a clot in the popliteal, this is a big clot, you know. And second, when you do Fogarty, always you pass it and you pull it back. So it's very rare, you know, to get anything embolied down, you know. So the only thing we go below the knee when you do selective. And the second thing is that the exposure below the knee is more difficult than femoral, you know. And second thing, popliteal artery is not very good artery. When you open it and you suture it back, sometimes you get stenosis, you know. So really, we don't like to do below the knee unless if we're going to do selective tibia. If you can get away from above, always above is easier. And really, you can do completion angiogram. You can see popliteal. You can see your, you know, completion angiogram. Where here, when you do embolectomy from the popliteal and you close it, it's very hard to do an angiogram unless you put a catheter through the posterior tibia and you shoot some dye, you know. So really, from technical standpoint, is not, you can do it, but it's not the best option, you know. So when the clot only in the popliteal, no, I'll try to get it from above. If it's going to the trifurcation, then I'll go from below.
Okay.
All right.
Okay.
So D.
D, surgical thromboemblectomy via left below knee incision. I think this is the answer.
Yeah.
And last one, surgical thromboemblectomy via left posterior tibial incision at the ankle and retrograde embolectomy. It's not a good option.
Not really, because
Yeah, it will be difficult.
you can clean up the posterior tibia, but you cannot clean up the tibia, the peroneal. You can clean the anterior tibial, you know. This one, the only time we do it if you have posterior tibial, you know, distal occlusions, and you can get from above, then you can go from below. But this is, you see, when you do this one, you stuck to one artery. When you go below, you can clean up all of them. So it's not the best option. So your best option will be D, correct?
Yes, yes.
Great. All right, this is the right answer, right? Yeah. All right, let's go to the next one. Number 6. Should we go back, Muhammad, to you?
Yes, Doctor, ready.
Okay.
So catheter-directed thrombolysis is being considered for a patient with acute thrombotic lower limb ischemia. An absolute contraindication to thrombolysis is A, laparoscopic gastric resection within 10 days. B, uncontrolled hypertension. C, cardiopulmonary resuscitation within 10 days. D, presence of intracranial tumor. E, gastrointestinal bleeding within 10 days.
Okay. I mean,
So,
all of them looks, yeah, go ahead.
All looks are relative contraindication, but the absolute is the gastrointestinal bleeding within 10 days.
Yeah, that's correct. Absolute if you have a GI bleed within 10 days. Otherwise, it looks contraindication, but you can say it is not an absolute, you know.
It's relative.
Intracranial tumor, yes. I mean, it's contraindication, but not like if you have to do it, you have to do it, you know. Cardiopulmonary resuscitation is not. Uncontrolled hypertension is not. Again, all relative, really. Even surgery within 10 days is not nowadays, especially laparoscopy, not like the major surgery, like, you know, there's why I said laparoscopy.
Yeah.
So all these are relative. The only one, if you have a really active GI bleeding, you cannot do it. Or if you have intracranial surgery. If he has like a craniotomy, of course, you cannot do it. The other relative, if you have an eye surgery, also, I think this is not absolute. This is like relative, I think. You can do that also. I think that's all. Any question about that? I think it's straightforward, this one.
Yes.
Very straightforward.
All right. Rafat, we go back to you.
Okay, Abbas.
Let's get number 7.
Number 72 years old woman, is 8 hours status post pharmacochemical thrombectomy and initiation of ongoing right lower extremity thrombolysis via a catheter placed in the left femoral artery for acute limb ischemia.
Okay.
Intravenous heparin was given
Okay.
for the intervention and is currently infused through the left femoral sheath.
Okay.
The patient now complaining of left lower limb weakness.
Okay.
Okay. On examination, she is disoriented and noted to have a new weakness of the entire left leg and arm.
Okay.
The most appropriate immediate next step in the management.
Okay. Before we start. So this is patient came with 8 hours, you know.
Acute ischemia.
After 8-hour thrombolysis. No, she be on thrombolysis for 8 hours.
Oh, okay.
Yeah. So she be on thrombolysis for 8 hours. They give her heparin during the procedure, and then the femoral. In general, guys, you have to remember when we give thrombolysis, we don't give heparin. You know, all the studies showed giving heparin with the thrombolysis increase the intracranial hemorrhage. Okay. So we do not give. The only time we give heparin through the sheath, but it's very minimum dose just to keep the sheath open.
Yes.
So you don't give heparin, like you don't write patient on low dose or high dose protocol. This is wrong. The only thing you see like heparin, you know, perfused through the sheath just to keep the sheath open, because otherwise the sheath can be thrombosed when you go with thrombolysis, okay? But don't heparinize the patient, because otherwise you end with intracranial bleeding. This patient, he was given heparin during the procedures, and now he have heparin during the left femoral, but I don't know what they mentioned by through the left femoral sheath, because you can give it, but it has to be small dose. I don't know about the dose here. But in general, from the history, what do you think happened to this patient?
hemorrhagic stroke.
Yeah, so he has hemorrhagic stroke because he has left weakness, disoriented. So what do you do first when the patient gets hemorrhagic stroke?
CT, non-contrastive.
Before CT, he's getting thrombolysis.
Stop
So
the
nurse call you before you
the
get there and
catheter.
make the orders. Huh?
Stop the thrombolysis catheter and
First stop
heparin.
thrombolysis. Yeah, the first thing. Even if you're in doubt, don't wait for confirmation. Be too late, because you know TBA is very strong. So the moment the nurse call you middle of the night before the CT, if you think any doubt, don't worry about the leg thrombolysis. You see the leg get worse, no big deal. This is a live patient, you know. So the moment you hear the nurse tell you, okay, I think some change, stop the thrombolysis first, and then yes, I go for CT for whatever. But the first thing, stop thrombolysis. You know. All right.
All right.
So they said what the most immediate next step, see, but then tell you what the most like diagnostic next step, you know. If they said what the most diagnostic next step, I'll do CT, brain. But the most immediate appropriate next step, I will what? Stop that TBA. Well, let's see what they said here. Go ahead, Rafat.
A duplex of the left lower extremity femoral and infrainguinal arteries.
Will not help. It's useless, right?
Right.
So how going to help you with make diagnosis? Nothing. Yeah.
B non-contrast CT of the head.
This will be your next step.
Next step.
I mean, not immediate. Number 2.
Okay. C
Okay.
MRI of the brain.
I mean, we don't do it in acute stage, you know, because the bleeding, you need MRI. You see, bleeding, it can be seen on non-contrast CT. It's different from a stroke. Ischemic stroke, you need an MRI to see it. Hemorrhagic stroke, you can see it in non-contrast CT. Okay, so when patient comes to the ER with a stroke, we want, before we start him on heparin, we want to rule out hemorrhagic stroke, because if you give him heparin, then it become worse. So when patient comes here with a stroke, before we start him on heparin, and we presume this is an ischemic stroke, first thing we need to rule out hemorrhagic stroke. So the first thing we order non-contrast CT. The moment you see no bleeding on CT, then you can give heparin. Okay? You don't need an MRI because non-contrast CT can show you the bleeding. Okay? D,
stop thrombolytic confusion.
Okay.
This is and E, check BTT and reverse heparin if sub
normal.
Supranormal.
Yeah. Which doesn't make sense because not the problem heparin, the problem is the TBA, you know.
Okay.
So, and BTT will not help you, you know. Do you know how we watch TBA when you give patient TBA? How we watch him? What lab we order?
Fibrinogen level.
Fibrinogen level. Yeah, it's very important, you know, to follow up fibrinogen level. Okay. When we give heparin, we follow with BTT. But what else is important when you give heparin to look at?
Ratio, 1 platelet count.
What else? Platelet count. Yeah. So with the heparin, always look at the platelets. With the TBA, always look at the fibrinogen level. Okay. All right. Any question? I think this is just straightforward. Stop heparin. Okay. Number 8. We'll go back to you, Ahlam.
Yes.
All right.
76-year-old man present to the emergency room with ST elevation myocardial infarction and undergoes emergent cardiac catheterization and stenting by right femoral approach. The following day, he complains of significant bilateral foot pain. A physical examination reveals a palpable medial pulses but patchy bluish discoloration of the tips of the toes on both feet. The most likely explanation.
What do you think happened to this patient? He has
embolization.
Right. What kind of embolization? Is a clot?
No. MI? No.
No. We're talking about a clot. I agree. But this is what we call the syndrome. He has a blue toe syndrome. Right? The blue toe syndrome. Okay. So blue toe syndrome is a microembolization because he has a good pulses. You see, he has a pedal pulses. So we're not talking about a big emboli, you know. So don't confuse with they tell you ST elevation or MI. They just tell you that he has a cardiac catheterizations. After that, he has a blue toe syndrome. So he embolized, but most of his clot is atheroemboli or cholesterol embolizations. It's not a clot, because clot usually go to the major arteries. Usually you lose the posterior tibial, anterior tibial. Rarely you see like a microembolization with a clot, you see?
Yes.
So this is muscular Bluetooth syndrome secondary to that embolizations. I saw one case really very, very bad, not when I was in the state, exactly the same scenario. He has a cardiac cath, and next day his all toes are blue, and very, very painful, by the way, you know, when you get that. And it was cholesterol embolized. The problem, you cannot do much for this one. Heparin will not work because it's a crystal cholesterol embolizations. So how we treat this one? You know how we treat them? What's the best thing to give them? Give them antiplatelets. You know, this is the best way. Ask me on blood. We don't give warfarin because it's not a clot. Antiplatelets, why is that? They think that just make the platelets more viscous, so be easier to go through the small arteries, get more blood flow. The second thing, we try to do that also to do an hyperbaric oxygen. I think some people, they may benefit from that, because you know, hyperbaric oxygen can help with the microcirculations, you know, decrease the ischemia. Most of them they end with ischemia, but most of it will be like a skin level. I rarely see like the whole toe would be, you know, lost, even though the toe looks bluish. But most of the time, patient end with skin gangrene. Rarely they lose all the toes. So when patient comes with a blow-toe syndrome, first give me a lot of pain. It's very painful. Antiplatelets, not anticoagulant. Give antiplatelets. And if you have an HBO, I think albuterol HBO. This would be very helpful for him. All right.
Okay.
All right, let's see what the most likely explanation.
As we said, cholesterol embolization.
Okay, the first one. Let's see if the other one makes sense or not.
Thrombosis of the right external iliac artery. No, it's, this is large, this is small.
And then he has a pulses, right? He has a palpable pulses. So this is out of question because a palpable pulses.
Yes. Diffuse peripheral vasoconstriction, no.
No, because you don't see patchy. You see, when you have a vasospasm, the whole toes will be the same, all cold, you know, painful, but you don't see patchy. When you see patchy, it's a blue toe syndrome, you know? Okay.
Left atrial thrombus, no.
Okay.
Chronic limb-threatening ischemia of bilateral lower extremities, no. It's not chronic.
We have a pulses, okay? So the reason why it can be this one. So it's very straightforward, you know? So this is cholesterol embolizations, all right? All right, thank you. We go back to Amjad.
Yes, doctor.
Amjad, number 9.
Dr. Samer, any role of iloprost for this case?
Ilioprost.
Post-MI.
The problem ilioprost for a spasm. It's not a spasm, it's an embolic, so emboli, you know, so I think antiplatelets will work. I mean, you can try it, but I don't think there's any study showed. But even HPO is not 100%, you know, indications when you see the indication. But I saw them, which works. Even I have a patient here came a lot like that. They give her a Botox injection and she has damage to the skin. And we sent her for HPO and she did very well. So anything at the skin level, when you see like the same, like when you compromise flow to the flap, the reason why I thought the HPO will work, and you compromise blood flow to the skin, then the HPO will work very well. But usually antiplatelets is the main treatment, you know. Warfarin will not work. Ilioprost, I think you can try it if patient impatient, but I will not admit the patient to be on ilioprost. I would usually send him, you know, on antiplatelets. But if he's impatient, you can try it, but I don't think we have any strong evidence to tell us that this will work. Okay? Any other question? No. All right, Amjad, we go to you now.
Okay. 65 years old man presented with discoloration and pain in multiple toes of both foot. 2 weeks prior to presentation, he had undergo diagnostic coronary angiography by a right femoral artery approach. He has a palpable bilateral femoral, popliteal, posterior tibial, and dorsal pedis pulses. His past medical history include 40 back per year, smoking history until 4-year period, hypercholesteremia and hypertension. CT angiogram demonstrated diffuse atherosclerosis of thoracic and abdominal aorta. Initial medical therapy should include. So this is talking about the Bluetooth syndrome again.
Same thing.
Management.
Yeah. So the same questions.
Said antiplatelet.
Yes. Let's see what options they give us here.
Okay. Single agent antiplatelet therapy, dual antiplatelet therapy, anticoagulant with warfarin, anticoagulant with rivaroxaban, single agent antiplatelet therapy with anticoagulant with warfarin. Between A and B.
Right.
I think I'll go with B. I'll go with the dual antiplatelet regarding his another risk factor.
Right. I mean, you can do that because again, I mean, this is what I'll do. But the problem is that when you go to that data and the trials, not the trials, the papers, they look at the Bluetooth syndrome. For some reasons, they use a single agent antiplatelets, you know.
Single agent.
Anticoagulant for sure, no. Platelets anticoagulant will not help. So we are between A and B. But I'm saying if you want to go with the paper, they said single agent, but from practical point, I may give 2, you know. But I don't know this will add any benefit. You see, the problem, not everything in medicine makes sense, works, you know. That is why we have our trial and study and everything. So I think the answer will be, the single, you know. Control response statin, antiplatelet therapy, avoid further instrumentation if possible. They didn't mention what's the reference. But most of it, they look at some references here. And most of it, they give a single. But the most important to know is antiplatelets, you know? Yeah. All right, the last question will be for Maisa.
Yes, Dr. Samer.
You're still there?
Yeah. So,
number 10.
Number 10, this is a 67-year-old woman with a chronic obstructive coronary disease, history of tobacco abuse, factor 5, present with painful discoloration of her left grade 2. Her foot was warm and well perfused with palpable pedal pulses. She was initially placed on dabigatran but presented to the emergency room again with pain and discoloration of her right fourth toe. The CT scan is seen in the figures, and the most appropriate next step in the management is.
So, okay, before we look at that, she is 67 and she has factor V. What does that mean? She has hypercoagulable, right?
Yeah, factor 5. Factor 5. Yeah.
So she's hypercoagulable. She's a smoker. She has coronary disease. So she has a good pulses, but she came also with a Bluetooth syndrome.
Again,
the problem is that you put her on dabigatran, but even though she's still getting on the other side. So you start at first with the medications, okay? But she's still getting emboli. So that means medication alone will not work. This is the reason why they give you this scenario, you know. If they didn't put her on dabigatran, then my treatment will be give her, but as we talk about antiplatelets, right? Or anticoagulant because she's factor 5. But because they already give her dabigatran and they did not work because she came with the other leg, also not the same legs.
On the other one,
so that means we have to do more aggressive. Just tell you how you look at the question, the exam, and how you analyze this, okay? Because I want you to be more aggressive, okay? All right, what you look at here, we look at the aorta. What do you see in the aorta?
There is mural by projection from the aorta.
Here. You see it here? And there's some calcification here. So you have so this is the source keep sending emboli to the lower extremities, all right?
Okay.
Because it's different from, there's no procedure to say like a cholesterol embolization, you know? This is just, she has just hypercoagulable, you know? So now you have a clot in the aorta, which is felt, you know, anticoagulations. So what next do you think to do?
I think to better control it with the stent, I think.
With a stent.
With a stent, yeah.
Open thrombectomy will not work because not like a clot, you know, and usually the aorta is too big. Even if you go for number 6, will not bring this blood clot down, you know, because this is a big aorta. It's different from the iliac or SMA or something like that. You see, So even you think maybe embolectomy will not work in the aorta, you know, unless you have aorta occlusion or huge clot. But something like that will not work. So you have to, the best way, the safest way to go and stent it. Okay? The only thing, let me tell you from my experience, when you take this patient to surgery or to stent, when you do an angiogram, no way you can see this clot because in a posterior wall. So you do an angiogram, aorta looks normal. Then you're stuck. Where are you going to stent, you know? So you have to be very careful with that. So what I do in this situation, I use an IVUS. This is very helpful in this situation. With your IVUS, you can see where's the clot in the IVUS. Then the way I guided my stent. But just to go with a regular angiogram, majority of the case, you cannot see the clot. You see on CT, it looks very nice and beautiful here because you're looking on, you know, cut and it's a posterior. But when you do an angiogram, unless if you do like, you know, 3D angiogram, you have like, you know, a table with a 3D angiogram, then it's difficult to see it. So the best way in this situation to use an IVUS. Okay?
Okay.
All right, let's see what the options they said.
So first option is switch anticoagulation to warfarin with a heparin bridge. Patient is already on dabigatran, so
it will not help.
Yeah.
Okay.
B, perform an angiogram and initiate lysis of the lesion. It's not a good option. Also.
Yeah, you see, lysis of the lesion will not work when you have a clot on the side because all the lysis will be done, so will not work. Okay. Okay.
C, stent coverage of the aortic lesion with a stent graft. Yes.
Correct. Okay.
D, direct femoral exposure with thrombectomy. The lesion in the aorta, not in the femoral, so has nothing to do with the femoral.
Right.
Okay, and the last one, open aortic exposure with endarterectomy of the lesion. Well, that's a very big surgery compared to the stent. Stent is better.
Right, unless if you have like a young patient. Let me see how old. This is 67. Because one time I had the patient, she's I think 30 or early 30, and she has like similar lesion, big atheroma at the aortic bifurcations. And because she's young, I don't want to put her through, and just only localized lesion. I don't want to put her through, you know, to stent and everything. She's a young lady. So I did an open, you know, endarterectomy of the distal aorta. So this only, yes, it's a major surgery, but it's good for young people, you know. But somebody like an old, I think this is the best way to go with a stent coverage. All right?
Okay.
All right, I think the hour is over. So 20 questions. So we'll start 11 next, about guys next week. We're talking before the other guys to join us. Your exam on December 2nd. So next Tuesday or Wednesday will be the last one before your exam. Do you want us guys to write your questions and we can go over them? If you have any question, concern, because you're reading a lot of materials these days, I'm sure you come up with a lot of questions. Should we do it this way? Or just continue reviewing the visa? What do you prefer? Or just give you a break next week? Any suggestion?
I think a break, boss.
Okay, so you can study. All right, guys.
Yes.
Well, Doctor, if I can make suggestion, and
Yes. Yes.
we can make it on Tuesday and to review like the question we couldn't answer or we have debate
Well, I'll
on.
tell you. I mean, Tuesday be a good time, so you have time. You know.
Yeah. Yeah.
It depends how many. Tuesday morning, I will send you a message on the group, and we'll see. If you guys have a lot of questions, then yes. But maybe you don't have any question. Maybe everything is clear for you guys. Then we don't have to do that. I don't want to waste your time before the exam. Okay. So
Yes.
we'll communicate Tuesday morning. I'll put on the group what you like guys to do it or not. If you said yes, or the majority yes said yes, then we'll do it Tuesday. So you have a Wednesday free, so you can read before the exam. All right.
Yeah. I think it's better this way.
All right. Okay, guys. Enjoy the rest of the night. Take care.
Thank you.
Bye.